This was much needed presentation. Thanks so much. Our next speaker is Dr. Sonia Luthar. She is formerly from Columbia University Teachers College. She left New York for sunny weather at Arizona State University. She is one of the few people who studies low-income and high-income children as at-risk population. So thank you. It's all yours.
Thank you, Sergio. Thanks for having me. Good morning. Is it up?
Coming up.
There you
Yes.
go. Right. So, I started my career studying inner city kids in the Northeast, continued that, and but late 1990s had my first publication on upper middle class kids. 10 years after that, there was this editorial which officially declared these children as an at-risk population. Who are these kids? Our kids. We're not talking about .com. We're not talking about millionaires. Certainly, I'm not a millionaire. We're talking about upper middle class, white collar, educated parents and their kids. The way I've studied these communities is basically schools that are the kinds of schools we aspire to send our own children to. Lots of extracurricular offerings, good SAT scores, AP offerings, and all the rest of it. Across the different communities I've studied, you find that somewhere between 80 and 98% of the populations are white. In a couple of communities, you have maybe 10-15% Asians, and both Latina and African Americans tend to be few, percentage-wise. What do you mean by at-risk? In research on risk and resilience, the way a population is described as being at risk is in terms of statistics. And we have found that rates of serious distress are between 2.5 to 3 times as high among our kids as compared to national norms, and oftentimes even higher than those of the inner city kids that I've studied. What kind of problems? The domains of elevated problems vary sometimes by region geographically and in private as opposed to public schools. In the Northeast, we found mostly substance use, binge drinking, alcohol use, weed, hard drugs, serious rule breaking. This is like random acts of delinquency for no good reason. Graffiti, stealing, breaking things, and so on. Again, remember, I'm talking about elevated compared to national norms, and sometimes even compared to inner city kids. Northwest, we found some substance use, but much more of the self-injurious behaviors, alienation from parents, internalizing problems. And in one all-boys school where the rules about substance use were really draconian, there was almost none. Of course, it happened a lot more once the kids graduated, as the boys told me. But there was, again, high levels of internalizing. Bottom line, whichever way you slice the pie, you find in one or more domains, our kids are reflecting 2.5 to 3 times as high rates of problems as compared to national norms. Why? American dream, get a Lexus, you'll attain nirvana. The way you get that Lexus is you get to the most competitive schools, right, and make a lot of money. At the school level, you have the encouragement to do a lot of AP courses, right from, I guess, and you know this, from middle school onwards, kids are told, right, this is the track that you're headed on. Social comparisons. How can you be the best friend of someone who's competing with you for that same spot of starting on the basketball team as the center forward? Family stressors, as is true in all demographic groups. This is not unique to us. It's true of all groups. Given all of this, where do we start, right? I do research on resilience, and we are commonly accused of having these lists of protective factors and risk factors, and people say, okay, already you've told me about 20 things, where to start? This is what I'd like to talk about. My time today, really focus on, is where we're going with this. I started studying resilience. This is my mentor, Ed Ziegler, dug up this paper from the 1990s, did a book, did a few chapters. This is the most recent one that's, I just got the proofs. Here's the finding, and this is so resonant with what Nancy is talking about. Resilience rests fundamentally on relationships. If you have to start somewhere, where do you start? Relationships, okay? Having said that, which relationships? If you have to start somewhere, you start with the families. Are you with me so far? Yeah? Why focus on families first? if we're going to try and foster resilience among children, it makes sense to prioritize those factors that are potent, powerful, and also that we can change from the environment, right? So talking about genetic factors does not really help in this situation. Single most powerful protective factor is the well-being of the caregiver. In this demographic particularly, mothers are generally the primary caregivers, dads are generally the primary wage earners, often gone a lot, so sometimes they're even like weekend dads, come home on Thursday night and go back on Sunday night to Wisconsin, Chicago, Canada, wherever. And we have found powerful associations, even among these big hulking 18-year-old young men and young women. The relationships with their mothers is very strongly associated with their own well-being. So where we went with that is, okay, you want to foster their resilience, how about we talk about fostering the well-being of their mothers? I'm sure every mother in the room is going to agree with this. Being a mother is very hard work. Still more so in at-risk populations, and yes, this is an at-risk population. This is a summary article of the work we've done in the last 15, 20 years. I want to emphasize this. Before anything else, I want to say that affluent parents, that would be us, as a group, are not bad parents. We are neither neglectful nor disparaging, nor bad, nor unkind, any of those things. We care. We do our best. It is not being affluent per se, but living in the subculture of I can, therefore I must. I can achieve, I can go ahead, so I must. That is the resounding theme within our communities and families. So talking about mothers, what we must deal with, the tasks are prodigious. We have a very competitive, materialistic milieu where everyone's striving to be the top. It takes a great amount of fortitude to be the ethical, cultural compass to your children, deflecting each child's high levels of stress, all the time being loving and nurturing, enforcing stable and consistent limits for all of our children in the midst of rampant substance use and rule breaking among their peers, all the while coordinating multiple schedules of all our children and frequently ourselves as working moms. So this is the question then, what predicts to our well-being? Reasonable? If the kids are coming to us, a lot of the time, not saying we're the only people by all means, of course they're coming to other people, but if that's some point to start. How do we start with understanding what predicts to our well-being? We have got a research study going on almost 2,200 mothers. This is one of the biggest predictors of mothers doing well across different dimensions. Unconditional love. I feel seen and loved for the person I am at my core. Stop and think about it. This is what our kids need from us, right? I feel seen and loved. Unconditional love. We need it as well. What you put out, you need to get in. This is the conceptual model then. Relationships lead to influence, affect. And when I say relationships, I don't mean a cup of sugar. I'm talking about the unconditional love that mothers feel. Affect our well-being, which in turn affects our parenting, the way we perform at work, and the way we function in various other relationships and roles. Somebody asked this morning about causation, and how do we know about causation? Intervention trials are about the best you can do to test a conceptual model. So this was a psychotherapy that I had developed while I was still at Yale, at the School of Medicine, Psychiatry, with very low SES moms with histories of drug addiction, called the Relational Psychotherapy Moms Group. It's manualized, and based on, again, Nancy's talk was so terrific, understanding of the specific risk and protective factors that these women as a subculture experienced, which included, as you might imagine, things like intense social isolation, very little support from family and friends, and so on. A lot of stigma. Strictly non-didactic. Again, for a lot of these women, the feeling was that they'd got a big stamp on their foreheads, drug addict. So before people even saw them as a woman or a mother, what they would see is as an addict who was abusive to her children, not just neglectful. So the group is a 6-month intervention based on respect, support, connectedness among the women in the group. And we had 2 randomized trials, each 5 years apart, lasting 5 years. We found significant improvements in the mother's parenting, not just by their own reports, but by their children's reports. We found improvements in the children's adjustment And remember, oh no, I didn't tell you this, we never saw the children in the therapy. So the groups were run with the moms, and the children never came in except to be assessed before and after. And in the mom's personal distress, as per, again, not just their own reports, but by their clinicians who were blind to the treatment group, and by urine analysis, they showed less drug use. So to me, this is pretty strong evidence of, supporting. Conclusive? Absolutely not, but good evidence saying that, yes, if our conceptual model was working. Where are we going with this now? Groups for physician mothers at the Mayo Clinic in Arizona. This is the creme de la creme of physicians. This is the name of the group, Authentic Connections. It's based very much on our PMG, our group with addicted moms. Why them? Well, apart from the fact that our kids, upper middle class kids, are hurting, physicians as a group are at very high risk for burnout. Women more so than men physicians, and mothers still more so. Here's a statistic that absolutely baffled me. Suicide risk of physicians versus the general population is between 1 and 3 times for men, and can be 2.5 to almost 6 times as high for female physicians as compared to the general population. So we are doing weekly groups for 3 months. Again, this is manualized. We have 20 moms in the groups and 20 in the control group. This is the Mayo Clinic CEO, the administration, gave the moms 1 hour of free time per week to attend these groups. That's a very big deal. Somebody actually put a number to this. What does this amount to? $180,000 for these mothers to attend this very experimental group. These doctors are expensive, so 1 hour of their time. So authentic connections, there's 3 prongs. One is obviously within the groups. And by the way, the groups are being run by a psychiatrist who's board certified and very skilled and experienced in group therapy, and also thoroughly warm, empathic, kind, down-to-earth mother who sort of enfolds, which is the idea, enfolds and holds everybody in the group. So that's Judy, the therapist. The connections we emphasize are the authenticity in relating to each other within the groups. Pause for a second and say, these are very busy women, very, very busy women with very challenging lives. So for them to let barriers down and really speak to each other in the groups is difficult to begin with, but after maybe first couple of sessions, everybody is in and very comfortable and easy talking to each other. So that's one, the connections within the groups. The second is with friends and colleagues outside, and we actually have a name for it, it's our go-to people, which women are taking extremely seriously, recognizing, yes, that we need this as well. And professionals, and as and when needed, not professionals just for physical help. But this is, again, a finding that surprised me, that medical doctors are very, very hesitant to seek psychiatric help, not just because of the stigma, but because it could affect their evaluations and ratings. So God forbid if something went wrong while you were in surgery, people say, well, she was on antidepressants. I did not know this, but it makes perfect sense. So as I said, we have 20 moms in the groups and 20 controls. 11 are currently in the current cycle. We're 9 weeks into the 12-week program. And again, back to what Nancy was saying is, we give, but we try and learn. So we ask the moms, so what are we doing? What are we doing right? What would you like us to change? And are you finding this helpful? I also shared a couple of qualitative little remarks with you. They are so moving. What these women have said is so moving, their remarks. I'll always cherish our time together, and I look forward to this 1 hour every week. It's the one thing I remember not to miss when I come back to work Monday morning. Having this on an ongoing basis would be extremely useful for us in preventing burnout. Recommend for further use. So we had to give them a scale of 1 to 10, 10 being definitely. The mean score was 9.99. One mom said, actually, would you consider an emphatic 100? Why? How would you explain to other physician moms at the Mayo Clinic if we were to do this in the future? Why do it? These groups are a beautiful combination of a reflective experience and practical advice. For example, reflecting on the question of having a go-to committee versus actually going to your committee members and verbally and explicitly asking, will you be in my committee? So this is like saying, will you be my friend? Which we don't, believe it or not, we don't really have time, space, energy for, leave alone are told to. So what the groups do is gives these moms not just permission to, but a directive to go to your friend and say, would you please be in my committee? And they come back and say, yes, I have 3. If you feel overwhelmed working, being a mom and a wife, you need this. It's not hokey. It speaks to the heart, soul, and for the scientist in all of us, the mind. It just makes sense. I found this woman's word so moving. Beautiful. So let me go back to my conceptual model then, as I wind this up. Resilience rests on relationships. Mothers need that too. I feel seen and loved for the person I am at my core. We know that in our research. Here's what we're targeting, and it's important for many reasons, for the moms themselves, for their work, other relationships, for their parenting, and because we are not just the physician moms, but upper middle class, well-educated moms in general. Disproportionately, we're raising the leaders of the next generation. So our well-being and how we're able to foster the well-being of our children, being well ourselves, given the current status quo, disproportionately, these are going to be the leaders. It's important for all of these reasons, I believe, to do this. Closing note, what does this have to do with other moms? Well, I spoke to Barry Schwartz, who, I don't know, some of you may know, he does this work on choice. He's got this book called Paradox of Choice, and how basically too much choice is no good for us. After a point, choice becomes limiting. And Barry's take on this is, well, yeah, if it works for physician mothers, there's absolutely no reason why it couldn't work for lawyer mothers or CEO mothers in business, or for that matter, mothers in Washington or in academia. Right? So this is our hope. We are at, the thing is manualized, as I said. We've got the pre and the post. We've got our control. By the fall, we should have data not just on our psychological outcomes, but also we've got physical assessments, cortisol, immune functioning, and so on. I hope very much to be able to come back and report at some point that, yes, we were able to reach the hearts of these mothers and tend them. Just like mothers tend, that we're able to do some tending of mothers. Thanks so much.